Welcome to The Explainer. Today, we're tackling something that can be really worrying: abnormal uterine bleeding. We're going to walk through the exact step-by-step playbook doctors use to figure out what's going on. So, when a patient comes in reporting this, where does the doctor even begin? For the person experiencing it, it can feel totally chaotic and scary. But for the doctor, it's actually the start of a very methodical investigation. This isn't just guesswork, not at all. It's a really logical path to get to the right answer, safely and efficiently. So, let's get into it. The best way to think about this is like we're on a diagnostic journey, following the clues just like a medical detective. We're going to follow these clues step by step and see exactly how a doctor sifts through all the possibilities to crack the case. Okay, so here's our game plan. We'll start with the first big clue: age. Then we'll look at the two different paths that clue leads to, one for postmenopausal women and one for those in their childbearing years. And finally, we'll see how it all comes together. All right, section 1, the first clue: age. This is the big one. It's the fork in the diagnostic road. The very first, most critical question a doctor asks is about a patient's reproductive stage. Are they postmenopausal or are they still in their childbearing years? Because the answer to that one question changes absolutely everything about what happens next. And what's so interesting is that it creates two totally different starting philosophies. On one hand, for postmenopausal years, the main concern is ruling out serious conditions first. It's a safety-first approach. But on the other hand, for childbearing years, the investigation starts by ruling out the most common causes. It's about efficiency. Let's check for the usual suspects first. Okay, let's follow that first path: postmenopausal bleeding. This is what we're calling the safety-first investigation, and the guiding principle here is simple but really important. When a postmenopausal woman has any bleeding, you investigate for the most serious potential cause until you can say with 100% certainty that it's not that. Now here's the thing. The most common cause is usually something called atrophy, just a harmless thinning of the uterine lining. But the most dangerous cause is an endometrial malignancy. So even though atrophy is way more likely, the entire process is built around that guiding principle. Always rule out the most dangerous thing first. So how do they do that? Well, the investigation kicks off with a pretty simple, non-invasive transvaginal ultrasound. It's just an imaging test, but it's hunting for one very specific, very important clue. How thick is the endometrium, the lining of the uterus? That measurement is step 2, and it's key. And based on that, a biopsy might be necessary. And it all comes down to this number: 5 millimeters. That's the magic number. It's the critical thickness threshold for the endometrium. This is the line in the sand that tells the doctor, okay, we can be reassured, or, we need to look closer. It's the key piece of data they're looking for. And this really breaks down the two possible outcomes. So if the result is less than 5 millimeters, great news. The diagnosis is almost certainly atrophy, and the treatment is usually just a local estrogen cream. Pretty straightforward. But if the result is more than 5 millimeters, well, that's considered suspicious for malignancy, and a confirmatory test is needed. You have to keep going. And that confirmatory test is an endometrial biopsy. Now, that might sound a little scary, but it's a standard procedure where they take just a tiny sample of the uterine lining to test it. This isn't about screening anymore. This is about getting a definitive answer. It's the only way to 100% confirm or, and this is what happens most of the time, rule out anything serious. All right, let's completely switch gears now and jump over to path number 2, bleeding during the childbearing years. The logic here is totally different. This is a process of elimination. Instead of assuming the worst, you start by ruling out the most common everyday causes. But first, what do we even mean by abnormal uterine bleeding, or AUB? It's important to know this isn't some kind of judgment. It's just a clinical term for any bleeding that's different from a woman's own regular cycle. Maybe it's the timing or the duration, which is normally 2 to 7 days, or the quantity. Like if you're seeing blood clots, that's a sign of a heavier flow. It's all about what's not normal for you. So the initial investigation here is all about ruling out the usual suspects. Step 1, check the history for contraception use. Some forms can definitely cause irregular bleeding. Step 2, run a pregnancy test. That's another really common cause. Only after you've ruled both of those out do you move on to step 3, which is conducting an ultrasound. Okay, so if it's not contraception and it's not pregnancy, the ultrasound is looking for the cause. And doctors have this really great mnemonic to organize the possibilities: PALM-Cohen. The PALM part stands for structural issues, things you can actually see, like a polyp, adenomyosis, a leiomyoma, which is just a fibroid, or a malignancy. The Cohen part is for non-structural issues you can't see on an ultrasound, like a coagulopathy or problems with ovulation or the endometrium. Now remember that 5 mm magic number from before? Well, forget it for this path. Here, the number is 10 millimeters. The normal upper limit for endometrial thickness is double, and that's because a thicker lining is completely normal during your childbearing years, thanks to hormones. So anything under 10 millimeters is generally not a cause for concern. The bleeding pattern itself gives even more clues. For example, is it menorrhagia, which just means a really heavy flow? That often points to a problem with the uterine muscle itself. Or is it metrorrhagia, which is irregular bleeding between periods? That clue suggests the issue might be with the endometrium or something hormonal going on with the ovaries. So what happens if the ultrasound comes back totally clear? No structural palm issues are found. Well then, the investigation pivots. The focus shifts over to those Cohen causes, the non-structural, functional stuff. And that usually means it's time for a hormonal profile test to see what's going on with that side of things. All right, so we've gone from all those clues to a much clearer picture. We followed the two big investigative paths and saw how doctors take a symptom and systematically figure out the cause. So what are the big things you should know? What's the bottom line? Okay, here are the key takeaways. First, this whole process is super methodical. It's not random at all. Your age and reproductive stage, that's the most important starting clue. From there, doctors either rule out the most serious causes or the most common ones first. That ultrasound gives them critical information to guide what happens next. And once they identify a cause, whether it's structural or functional, that leads directly to a targeted treatment plan. See? It's a system. Look, the point of all this isn't so you can diagnose yourself. It's so you can be an empowered patient. It's about demystifying the process. Because really, the most important step isn't about knowing the answer. It's about asking the right questions. And the first, most important question starts with you. Go start a conversation with your doctor.